Welcome, everyone. Thanks for joining at the end of our Saturday. You've made it through a long 2-day conference. Hopefully you've enjoyed all of it. And here for your last session of the day, which is really exciting, I have Katie Hogue, and I'm excited to present her for this last topic today. So we'll dive right into it. I'm sure Katie will say herself, there could be some issues with the storms that are happening in her area right now. Hopefully we won't lose her. So I'll dive in so she can take over and we don't get cut off by the weather. So Katie, I'm really excited to introduce, is a primary care nurse practitioner and the Director of Nursing, Clinical and Community Programs for the West Parry Sound Rural Nurse Practitioner-led Clinic. She is actively involved with the Ontario Health Team development locally and provincially, in her role as the President of the Nurse Practitioner-led Clinic Association. She has 16 years of clinical experience in both urban and rural settings. Katie has worked in rural primary care for 9 years, and through her work in rural primary care clinic, developed a passion for integrating interdisciplinary care teams. She has a keen interest in enhancing interdisciplinary teams and system transitions. In particular, she is passionate about integrating mental health and addiction support into all sectors of healthcare access. She was a leader in the development of the NP-PHC Rural Nurse Practitioner-led Clinic and RAM. She continues to advocate for funding and ongoing intersectoral collaboration. So excited to have you here, Katie, and I'll let you take over.
So this talk is on the structure, growth, and development of an addiction medicine and rural service and the struggles and tribulations that come with that. And so I was supposed to be two of us that were presenting. Connie Foster, my colleague, unfortunately had an urgent situation, but I do want to speak to her because she really is one of the programs, and she has been my mentor for addiction medicine. So Connie Foster, she's a nurse practitioner. She has over 35 years of healthcare experience. She's also an Ojibwe First Nation woman and a registered band member at the Shawanaga First Nation. She's a nurse practitioner with primary healthcare practice at the West Parry Sound Health Center. And her site is actually on a First Nation community, Moose Deer Point. She's the co-lead for the Rapid Community Addiction Treatment Team. She's also the medical lead for Mama Way, a withdrawal management service. And she also is a co-lead for the Parry Sound and Area Regional Drug Strategy and provides addiction medicine services for Greenstone Recovery. And she's done that for the last 9 years. And she continues to be a strong advocate for culturally appropriate services. So I'm sad that she's not here today, but I'm happy to be presenting on our fantastic team. So the objectives of this talk are really to highlight the growth and structure of our rural medicine innovation with interprofessional approach, partnering agencies, and the success which has stemmed since May 2019 to current. We also want to highlight the change in practice and the approaches for the West Parry Sound Health Center in integrating addiction medicine services and education from within the hospital setting to the community, and including withdrawal management, now spanning over 3 regions, Simcoe, Muskoka, and West Parry Sound. We'll discuss the change in addiction medicine services and approach within the healthcare system to create a system that reflects the needs of a unique population of both Indigenous and non-Indigenous people. And I'll provide an overview of our model, the growth and development, which will also highlight the expansion of services and integration of different modalities with a multi-regional approach that include partnerships focusing on prevention, harm reduction, treatment, and enforcement. Additional points of discussion are really around the reality of addiction problems in rural Northern Ontario and how a nurse practitioner-led funding barriers can address how we've addressed gaps and services for large Indigenous population, including culturally appropriate engagement. We're also going to talk about the partnership with some programs that we've have really been essential to address these barriers and what the priorities of those partnerships are, how we implemented the partnerships, and what is the role in our service, what relationship building was needed, what people and resources have been needed to achieve what we have achieved to date. So including our human resources, the funding reality, and the strategic program components to offer service as a regional approach. I also will chat about how this intersects the patient and actually delivers the care to them. So talking about our RAM program, addiction medicine consult team, our primary care partnership, community agency partnerships, and that total wraparound care. And then what are the next steps, an area of growth that we're focused on for the future. So questions to ponder. This will really help with understanding where you're from. So what is your practice setting? Urban Southern Ontario? Are you urban Northern Ontario, such as Sudbury, North Bay? Rural Southern Ontario, rural Northern Ontario, or a First Nation community? Great, thanks for taking the time to answer that. What is your biggest barrier to practice? So I know they're not correlated, but it is interesting to see what barriers to practice can be. So whether it's location, interdisciplinary resources, funding, human resource limitations, or lack of training and education. Thank you so much for taking the time to vote. So when you develop a program, it's really important to understand what your vision is and what the purpose of the program really is. And so our vision really looked at the root cause of the issues that we were seeing in a patient and a person-centered approach. We really wanted to make sure that we were looking at the barriers to treatment, why we were finding that our patients were not having easy access. Are there systemic issues, historical issues? Is there historical trauma, cultural barriers? We wanted to create a patient and a person-centered program that works. So making sure that it's interdisciplinary, including medical and traditional medicine. Culturally safe and aware, all of our team members have taken the Indigenous Cultural Safety course. We wanted to make sure that it's trauma-informed, there's low barrier access, it's safe and effective transition from the community to acute care and back to primary care. We also wanted to ensure that there is interorganizational collaboration. We don't have the funding. Not one organization has all of the funding to do it all. So we really need to work in partnerships. So what are the services that we provide? And we've really grown, and you'll see in a few slides later on to see how much growth we have had. We provide Rapid Access Addiction Medicine Clinic, which is a low barrier, culturally safe clinic for those 16 years of age and older, looking to make change in their substance or alcohol abuse. This RAM program is held twice a week at an acute care hospital ambulatory care clinic. It is adjacent to the emergency department, so we're able to do cross referrals. And on that note, we have an addiction medicine consult team that provides consultation and support to both primary care, emergency department, inpatient, and community programs. So it really is that wraparound approach. And so the nurse practitioners that are providing care for the RAM program are also providing the addiction medicine consult team program. On the off-RAM days, they are available for consults 7 days a week. They're really dedicated to the work that they're doing. We also provide traditional safe bed support. So at any given time at our acute care hospital, we have at least 2 patients that are in for some sort of withdrawal services. And so our addiction medicine consult team will go and see them. They'll provide consultation to the hospitalists or internal medicine, depending on what unit they're on, and then really do that coordinated approach for discharge planning so that there's a safe and safe transition and navigation through the RAM program. We also provide some primary care for high-risk and orphan patients that don't have a local provider or who have difficulty getting to see their provider. We do some shared care as well. So how do we get started? This is interesting. In 2019, we were approached by CMHA Muskoka Parry Sound. They were awarded the RAM funding, but they weren't able to find a physician to support the program. So Connie Foster, who had been working at Greenstone and had a passion for mental health and addictions, she and myself met with CMHA, and we formed a partnership to deliver the medical care through the RAM partnership under the umbrella of the hospital. RAM launched in May 2019, and as I noted, it's 2 days per week, so Mondays and Thursdays, so that we have that 3-day transition for agonist therapy, and it's held in the ambulatory care clinic. Given the organizational differences and COVID, we did separate officially from CMHA, but we continue to work together through cross referrals. We continue to have CMHA counselors at our weekly meetings through case consultation. Our nurse practitioner-led clinic program also grew to support the RAM program, the addiction medicine consult team, and that safe transitional bed support. We have OTN support at all 6 of our nurse practitioner-led clinic sites, which span 190 kilometers all the way from northern Port Loring up to Moose Deer Point, or I should say down to Moose Deer Point, which is our most southern nurse practitioner-led clinic. In April 2021, the West Parry Sound Health Center was awarded the RAM funding. So the funding's minimal, but it is appreciated because we have the connection and collaboration to our hub. It's a hub and spoke model with HSN Sudbury and many other spoke sites. There's a community of practice and ongoing advocacy for the work that we're doing. We still don't have any human resource funding, but we've written 9 proposals and counting, and I had the opportunity to meet with Minister Thibodeau this week to support our case for why addiction medicine really does need to be funded in primary care and in other interdisciplinary care teams. We've successfully presented at 2 grand rounds and an open house, as well as through our family health team, the OPP, and multiple community of practices. So we really want to get the word out there that what RAM does, and in addition, creates partnerships with other primary care agencies to build champions and education there as well. The strength of the team is each member. The strength of each member is the team. I love that. Our team has grown, and it consists of 3 nurse practitioners. They share clinic days as well as leadership and on-call for the addiction medicine consult team. There's 2 primary co-leads, that's Connie Foster and Teresa Wetzler. And we are onboarding additional nurse practitioners. I'm also available for support. I'm a nurse practitioner, and I do provide consultations and in-hospital consultations when RAM is not there. So I'm the director. I am also a director at the acute care hospital, as well as I oversee the nurse practitioner-led clinic. So it really does allow for that integrated full flow of consultation through acute care hospital, primary care, and community. My official title is Director of Nursing Clinical and Community Programs. So it really does go through the acute care and community spectrum. We have 2 social workers that work at the nurse practitioner-led clinic, and they provide support to clients. They also help with the navigation for local programs such as CMHA. And as I mentioned earlier, we do have a CMHA representative that does come to all of our patient consultations and our patient meetings, so that we can figure out what makes the most sense for that individual client. And if they're already part of a program with CMHA, we don't want to duplicate services. So it really is that wraparound approach without and making sure that it's efficient. We also utilize 2 of our administrative supports. So we have an administrative assistant at 2 different sites of our nurse practitioner-led clinics that also do call protocols. So if a client has been referred to us and we haven't been able to get a hold of them for intake, then they're responsible for doing that, as well as tracking the nurse practitioner consultations. So what are the local realities? Why did we get into this business? We have many patients without primary care access. We've had physicians retire, leave. We had an unfortunate passing away of one of our physicians that cared for a lot of patients with mental health and addictions, and they were left without a primary care provider. The hospital capacity is often at capacity 100% and stretched even more with COVID-19 and human resource limitations. There's also been a higher acuity. We've had a lot more overdoses, a lot more opioid and alcohol addictions. So what is the approach that we use to face these challenges? So we're leveraging our partnerships with CMHA, community paramedicine. I am the medical director for the community paramedicine program, which allows that flow through again for that community consultation. So if we have a client that visits RAM and needs a check-in or needs an additional support in the community, we can utilize our community partnership with the community paramedicine. Our nurse practitioner-led clinics, if there's a client that does not have transportation, we can see them through OTN, or we can do consultation with the primary care provider, nurse practitioner at their site. So for example, if the client lives closer to our Rosso nurse practitioner-led clinic site, we may ask the Rosso nurse practitioner to see them, and then we will provide that consultation. We also have a partnership with the OATC, and I'll chat a bit more about that, but that also includes support for 6 First Nation communities locally. And as I mentioned earlier, that streamlining is really one of our approaches. We want to streamline services so that it's a one-stop, no wrong door approach. So anywhere people are accessing care, whether it's their primary care provider, the emergency department, acute care, or in the community, they can get connected with our RAM program. How we have grown, and we really have grown since the inception. When I was putting together these slides, I really couldn't believe, until you look at the numbers, how quickly our program and our services have grown and the need in the community. When we started, we were seeing 2 patients per quarter. So you can see, looking at the way the encounters are going upwards per quarter, as we get into the pandemic, we almost doubled quarter 1 in 2021 and quarter number 2, and now we're close to 300 patient encounters per quarter. I mentioned earlier quite a few times our collaboration, so I just wanted to highlight again some of those collaborations that have made our program successful. So CMHA, Muskoka, Parry Sound, we have weekly roundtables and shared care discussions with ongoing cross referrals. We also have a partnership with West Parry Sound Health Center, Mamaway, and Simcoe Muskoka CMHA for withdrawal management services. And it's a mobile withdrawal management services where our nurse practitioner provides that ongoing care. We have a partnership with the family health team. We provided engagement even prior to the RAM launch. And then we've also done some shadowing with some physicians so that they feel comfortable in their primary care practice. And since then, we've had more physicians that have been more comfortable prescribing opioid agonist therapy and doing really consultation rather than sending them directly to RAM, which is helpful because we are unfunded and over capacity, I think, at any given time. The West Parry Sound Health Center is another partnership that I had mentioned earlier. The emergency department physicians have been really instrumental in partnership, and in the last few months, we've been able to offer Suboxone inductions in the emergency department with partnership with our on-site pharmacy. We also have pre-printed orders that we've developed for inpatients, and the hospitalists or nurses can call us at any time to speak about those PPOs and get education. Oh, I'm just going to go back. I forgot about District Social Services. So the DSAP, they provide safe housing. So for patients who don't have safe housing and they can be inducted in the community, but they don't have a safe place to be, the District Social Services have a few projects where we're able to offer safe housing, and with partnership with CMHA to make sure that they do have safe support while they are starting their induction. So RAM and AMCT, so the whole purpose is really to link acute care and community programs to primary care. The same care team is following the patient throughout the course of care, whether they're in the community or the hospital. So that really provides that partnership delivery of care to patients where they feel comfortable and they build that trust relationship with our program. The emergency department and the RAM being in proximity has been very helpful. As I mentioned, they're now doing Suboxone inductions. They have also started a naloxone program, and we have naloxone on site as well. So primary care and RAM, that partnership really is augmenting primary care, not replacing it. The purpose of RAM programs, if you've been to many of the other talks, are to make sure that patients have access to addiction medicine, but also that they have primary care. And so I mentioned that we do provide some primary care for patients that are orphaned, but the nurse practitioners that are involved with RAM and AMCT do have full primary care practices. So we really try to work with primary care providers and work with patients that have primary care providers to provide that support for them so that they feel comfortable to support them in their own primary care practice, and then transition them back to primary care. So they don't stay with our RAM program or AMCT program for a long period of time. It may be 3 months, 6 months, or a year, depending on what the client needs are, but they will go back to primary care and they will have the full support of our RAM and AMCT team. RAM also, our nurse practitioners have been providing support for learners. So as I mentioned earlier, we've had some local physicians that wanted to be champions in their primary care practice and emergency department. We've also had some placements with RAM clinicians through NOSM, which has been really great. And we continue to facilitate exposure for nurses or other interdisciplinary care members that want to come and see what our RAM team is about. We have had many students, social work students or addiction therapy students that have also joined our team as learners to learn about our program. and be able to bring that back to their agencies. And most recently, our mobile withdrawal management service, as I had mentioned earlier, it's a partnership with Mamaway. Mamaway is the fund holder, but they've partnered with CMHA, Muskoka, Parry Sound, and Simcoe, and they needed medical support. So we've provided that support through one of our nurse practitioners, and really to bridge that gap to Parry Sound. There's a lot of services that we don't have access because of funding limitations, and this allows us to get some access to the local Parry Sound area without having funding just with this partnership. The geographic boundaries for that program, so the primary catchment area is really North Simcoe, Muskoka, Lynn, and but through the West Parry Sound Health Center, this allows us to go all the way up to Port Loring, our most northern area. But if we look to the south for the withdrawal management program, it goes all the way down to Collingwood. Our Indigenous partnerships have grown, and they continue to grow. We have 6 First Nation communities that are along this 69 corridor. And as I mentioned earlier, we do have a partnership with a local OITC to facilitate opioid agonist therapy delivery and inpatient community direct observed therapy. We have primary care supports through our 6 nurse practitioner-led clinics. And I mentioned earlier, we have our Moose Deer Point NP-PHC that's stationed right on a First Nation community. Our integrative successes related to COVID. So there's always a silver lining that you have to look for whenever you're going through a challenge, and COVID is just one of those challenges. So part of my role, I'm also the medical director for the assessment center and the COVID-19 lead at the West Parry Sound Health Center. We recently have had a COVID-19 outbreak in a few of our communities, actually a few of the Indigenous communities, and one such community had a high number of people who were traveling to either Sudbury or Parry Sound to the OATC for methadone or Suboxone. Most of these people that required therapy actually didn't have transportation, and they were in quarantine. So we ran into an issue where people weren't able to get their therapy. They didn't have delivery services. So I called the pharmacies in all of the pharmacies that were involved, and we were able to secure delivery to the community. And what we found was that people that weren't initially compliant and missed their doses and weren't consistent with their therapy were consistent, and they wanted the delivery. And that was a huge barrier to these communities being very rural, Indigenous, and not having transportation. So through that partnership and through that silver lining, we were able to build a partnership with the OATC to form a program where they are providing delivery services to this community, and then with the hope that the rest of the communities have access to that program if they were interested. And so Connie Foster, who's our West Parry Sound Health Center Indigenous lead, that's part of her role, is to provide ongoing engagement with the local First Nation communities and really understand what the local community needs are and help facilitate that, in particular for addiction medicine. So as I mentioned earlier, Connie Foster is also a co-lead for the Parry Sound Drug Strategy, and we have a number of partners that sit on that strategy, including OPP, CMHA, District Social Services. And the purpose of that table is really to reduce the stigma around drug use so that people can get the help they need. And they have a number of initiatives. So they have a website that people can go to and follow. And in development right now is a Facebook page that's going to include Facebook Live Q&As with Connie Foster and other clinicians so that they can either clients themselves or family members can go and ask questions about how to access help for either themselves or their loved ones. So what's missing? What's missing right now is funding. So right now, as I mentioned, we're doing this off the side of our desks. So we have full-time practices. I'm a director at the hospital, and the NPs are working over and above complement. 60% of their addiction medicine consults are done after hours or on the weekends. So really looking at that funding is our key priority so that we can sustain this program. All of the social workers also have full rosters. So we are looking for program funding for nurse practitioner, social worker, our administrative support, but we also wanted to add a registered nurse. That registered nurse will really help with the flow through between the acute care, community, RAM, and primary care programs. So for example, if we had a client that was admitted to hospital and we were looking at transitioning home, that registered nurse would help connect that person to RAM, AMCT, so that the NPs aren't the ones that are always doing that work, and the social workers who have full practices already. They also will provide the education. So what we found is that patients who are admitted with opioid or alcohol withdrawals, the nurses don't necessarily have the skills or knowledge to be able to provide the support going through it all. And there's a lot of mismanagement, unfortunately, where people aren't treated appropriately, not given the appropriate amount of medication that they need because they just don't have the education. So the nurse would be able to provide that support, the on-site education, and follow through. So that's the end of the presentation, and I'm sorry it was just the Katie show. I was really looking forward to having Connie here, but as I mentioned, she had an emergency. So Connie did mention that if anybody wanted to reach out to her, if they had any questions, she really is our expert. So if anybody has any clinical questions, she would be the best person to reach out to. For any program development questions, you can certainly reach out to me. And clinical questions, you can ask me, but I would probably pass it on to Connie, who really is our local expert.
Amazing. Thank you, Katie, so much. I'm so thrilled to have you here. You are an incredible person, an incredible female, a leadership female and nurse practitioner. So thank you for everything that you're doing. And thank you for powering through the internet and the storms that you're raging right now. So that's amazing that we got through the presentation. Thank you, everyone, for still being here this late on Saturday on the second day of a conference. And please feel free to throw any questions or comments that you have in the chat box. It is still open. So I'll give us a couple of minutes for that to see if anything else pops up. Otherwise, as usual, I have lots of questions, so I'm sure I can keep us busy. But let's see if anyone else wants to throw something out there. Thanks for all of your good work. Who do we direct advocacy to for your funding?
That's a really good question. So one of the barriers that we have is transfer payment between mental health sector ministry and primary care and acute care ministries. So that's a big red tape issue that we've been fighting for. And I know other organizations are fighting for that as well. So really advocating for easier transfer of payment for mental health and addictions funding to be embedded into other sectors other than mental health and addiction so that we can have appropriate access to that funding. There's a lot of funding that's coming out for mental health and addiction. We're not going to be able to access that unless we are a mental health and addictions program. So just continuing to talk about that as being a red tape issue. And then just locally, if you have ongoing issues with funding locally, finding out what your local issues are with accessing that funding.
Absolutely. Good point. And thanks for the question, Angie. I know, Katie, you'd already answered so many questions that I had about being stretched so thin, which you addressed at the end there. And, I was just curious what you thought your needs were, because it does sound like everyone involved in all of these teams and programs is stretched so thin, and yet you're making it work and doing the important work that's required. So it was good to see that obviously advocacy, increased funding for increased programming and filling gaps that already exist in the programs that are there is something you are actively working on. Do you know, like to follow up on Angie's question, do you know what steps are next for you or your team in terms of advocating for more funding for you guys specifically?
Sure.
Yeah.
So I mentioned earlier, I had such a great opportunity to meet with Minister Tibolot this week, who is doing roundtable questions with communities about addictions and mental health support. So it was great because CMHA was there, the District Social Services, HANDS were there. We were able to talk about our local issues. And so we have resubmitted our proposal to the Mental Health and Addictions Ministry, as well as our local LIN, who is our hub and spoke. So our hub and spoke site is HSN, and we have, I think I mentioned 9 proposals that we've submitted and resubmitted. I just continue to send them in. And, it's interesting. Our nurse practitioner-led clinic started off as 6 nursing stations. And it was part of my master's work. I did a proposal around inter-D care and how we didn't have the interdisciplinary care at these 6 sites. It was an NP and a secretary. And so with my master's proposal, I was able to use that to get funding as a nurse practitioner led clinic. And I think we submitted that 5 or 6 times before we were actually funded. And so I did my master's in 2000. I started in 2012. I graduated in 2014 as an NP. And so I must have run funded in 2018. So it really tells you like how long it takes for this advocacy work. And you're not going to get funded the first time. I've just come to terms with that. But just being persistent has really paid off in my, and the more tables you can sit at. So the other thing that I didn't mention, I'm the Nurse Practitioner Led Clinic Association president. And so I sit at really awesome Ontario tables with the Primary Care Collaborative, which includes AFTO and CHCs and OMA. And sitting at these tables also allows us to advocate for more funding for not just our NPLC, but other primary care clinics. So we did write a proposal. The Nurse Practitioner Led Clinic Association as a whole wrote a proposal to embed mental health and addictions funding into all 25 of the NPLCs across Ontario. And we'll continue to do that work. So the more tables I can sit on, it feels like I'm never not at work, but it's such important work. And I just feel like I'm so privileged to be a part of this work and be able to advocate at the tables that I'm at.
Yeah. It does sound like you wear a lot of hats and you're balancing it very, very well. And that's good for, I think, everyone to hear how much effort it does take, that this hasn't happened overnight. It takes effort, expect rejection, and be persistent with it so that we can make the changes that we needed. So thank you. That's really good to share. Um, Please feel free to keep putting questions in the chat box if you have them. I don't mean to put you on the spot with this one, Katie, but I am curious with all these programs that you have, are you guys collecting any metrics? Do you have any already about volume, capacity? Because it would be so great to be able to replicate what you guys have done in such a short period of time into other communities. But of course, then the question is, what capacity can that really handle? What's the volume?
So it's so funny. I was just going to mention about data, and then you brought it up. So I am a data geek. I love it. I think it's the only way to get funding. And so we're building the program. If you build it, they will come. That's sort of the mentality that I have. And so within that, we continue to collect data. So we collect the data that's required for the RAM program funding, but we also collect additional data, including our AMCT consults. So are they done? We've built it into an encounter form. We use TELUS PS Suites as our platform for EMR. And then we built an encounter form that also collects on the encounter. Was it a consult? Was it a physician consult? Was it a CMHA consult, OPP? So where did we get the consult from? Was it during RAM hours, after RAM hours, after clinic time, so that we know when these are, and that's where we were able to gather that information that 60% of our consults are actually happening outside of clinic time. So yes, we collect a ton of data. And when I first started collecting it, my team was less than thrilled. They were not happy with the additional work, but we were able to create a template that just made it easy and part of the workflow. That setting that up the encounter, I think was the biggest hardship. But once you have it built into your system, it becomes seamless and just part of your flow.
Mm. And you're in such a unique position to be able to see, I think, the frustrations of the team, being a nurse practitioner yourself, knowing the workload that's added on. Having said 60% of your encounters are after hours or weekends, nobody wants to do those in general. And then to put that extra work on top of them, and then wearing your other hats in terms of putting these proposals forward, knowing that the data makes the program, that there won't be funding without it. So that's great that you were able to balance that and make it more, I won't say effortless, but improve the process for those that are actually having to do the work of collecting that data so that we can get that funding. That kind of segues me into my next question, if that's okay, for communication. So it's difficult in general in all settings, in rural settings for sure. You have so many different programs and locations at play at one time. You'd mentioned PS Suites. Is that something that's shared between all of the sites, or how does communication happen best? Especially when you had mentioned full-time practices in primary care, consults that happen in the hospital, as well as community programs ongoing.
Great question. So we are so lucky, and don't let me forget, because I do want to talk about collaborative quality improvement plans too.
Perfect.
I think it's really important in the world of OHTs. So we use PS Suites. Our 6 sites are integrated. The hospital, because the hospital is our fund holder for the nurse practitioner-led clinic, we're the only NPLC that's under the umbrella of a hospital, but that's because we started off as nursing stations. So we're kind of like an OHT, and we keep fighting for the funding for that too, because we are an OHT. We're already acting like one. We are fully integrated with their primary care program and improvement plan. So the 6 sites use TELUS Suites. If we're on site at the hospital, we can go into the EMR and use it that way. But it does not integrate with the acute care hospital Meditech. However, if we see a consult on the floor, so acute care consult, we can enter in our note through Meditech. So we do have hospital privileges. We can enter in our consult through Meditech, and then that gets transferred to TELUS PS Suites through POI or HRM. I can't remember which one it is, but it gets transferred. So the note directly goes to the primary care provider. So the family health team also uses PS Suites. We're not integrated with the family health team, but the notes can be directly integrated there. And then we do have access to the family health team where we can send them a note. But what we do is we fax them. So if we're not part of a shared care relationship, we'll just fax them the note that we've seen their client, and this is the treatment plan, and this is what we're hoping, And then in terms of communication with the NP that's providing the care for them, they do offer their cell phone numbers to the providers so that it's just direct consult with them. Most of the it's a small town, and that's a benefit of a small town, is everybody knows everybody. And so if they can't get a hold of any of the team, they usually call me because as you say, I have my hat kind of everywhere. So they just reach out to me, and then I'll let them know how to access care.
Perfect. And you had mentioned wanting to talk about the collaborative quality improvement plans.
Yeah. So quality improvement plans are required for acute care hospitals as well as primary care practices. And so pre-pandemic, we were already setting up a quality improvement plan. And one of the indicators, for example, was reduction of readmissions or visits to the emergency department. And we had met with a family health team as well, who had had some physicians that were also working in RAM and becoming champions within their own family health team. So we developed some shared indicators with primary care and acute care so that we're actively looking. We're not just doing our quality improvement plan to have them done for the ministry. We're actually looking at our programs and how we can integrate better. So this week coming up, we have another meeting with the family health team and nurse practitioner-led clinic and the acute care hospital so that we continue to do that work. And in part of my NPLCA hat, my president hat, I did, so I was at a table and they were talking about collaborative quality improvement plans for Ontario health teams and integration and how important that will be. And I had mentioned that we were already doing that. So I actually have been acting as a consult for Ontario Health for collaborative quality improvement plans as well.
That's amazing. Perfect that you can bring over that education, the stuff that you're already
Yes.
using. Can you give us an example of one of the topics, something that would have come up for one of those plans?
So, well, really, we're just talking about the RAM program. And so when you're looking at your indicators and reducing the number of visits, so you look at your visits in the emergency department, the repeat visits, and then you're looking at your denominator. So have your visits gone down, the repeat visits, and we were able to capture the client numbers because we use Meditech, so it's an unidentified client. So we would look at that. In terms of the emergency department, we would look at our volume for the RAM program and the AMCT program. And so those are the metrics that we're using. We're really just looking at those repeat visits and the reduction of those.
Perfect. Great. I'll just take a moment to say, because we have about 3 minutes left for this chat, that please, if you can, fill out the conference evaluation form for this session. It should be at the top of your screen now. And I'll just let you know, I do have one more question, but I'll just let you know after this, you can head to some of the poster presentations that should still be available if you've missed them so far. All of them were really fascinating. So something to dive into. And then we have our final wrap up discussion, I believe at 5:15 you can head to. Yeah, at 5:15 you can head to that one. So Katie, just one last thing that I was hoping, because this is, a huge part of everything that you've talked about so far, to end the conversation, can you tell us how important the role of interdisciplinary care and teamwork really is?
Oh my gosh, I can't speak enough about how important it is to have a team. We all have our specialties. I'm really passionate about connecting with other agencies, and I have that in my role. It's just built directly into my role. But I really do value and need to have the expert nurse practitioners that are providing the support to patients. Our social workers, we could not manage providing that full wraparound our social workers, that's doing the full integration, and looking at community resources, even just filling out forms, helping them figure out what agency they need to go to. Is it social services, or do they need CMHA? Do they need other services? Do they have a power of attorney? Those are all things that I would have no idea how to do. And that's why it's so important to be able to call a friend and know who your friends are, and then really have them as part of that full team wraparound approach.
Yeah, amazing. Agreed. And I'm so impressed by what you've done. Thank you, because it really is inspiring for all of us to keep advocating and keep seeking out that funding so that we can continue to develop our programs. So I think we'll close it there because there's less than a minute left. And I'll say thank you so much, Katie, for being here. And thank you, everyone, for attending this session and the conference as a whole. I hope you enjoyed it. And please, feedback is always welcome. You're getting lots of thanks and praise in the chat box,
Thank
Katie. I don't know
you.
if you can see that. Thanks, guys.
It, Thank you. It's a privilege, and it has been a privilege. Thank you.